Welcome, everyone. Thanks so much for joining, and welcome Dr. Paula Brady to the podcast today. Thanks for coming.
Thank you so much for having me. I'm excited to be here.
Great. So we have a very interesting topic today, We have a very interesting topic today. We are talking about urgent egg and embryo freezing, and also diving a little bit into the basics of ovarian reserve and what to check for and what to know as it pertains to your fertility and fertility treatment. So Dr. Paula Brady is the person to talk to about this. She received her medical degree from Columbia University and did her residency in obstetrics and gynecology at Harvard Medical School. She also did her fellowship in reproductive endocrinology and infertility at Harvard Medical School. If that wasn't enough, she authored a textbook while she was in school, the Handbook of Consult and Inpatient Gynecology. Dr. Brady has special interest in fertility preservation, ovarian reserve testing, diminished ovarian reserve, and ovulatory disorders. Dr. Brady and I see a lot of patients together, and I hear amazing things. She is a great educator and a great listener to boot, and her treatments have, at least from what I have seen, have been proven to be very effective. So Dr. Brady, let's start off with some of the basics on this topic. What kind of testing can be done on ovarian reserve?
That's a great question, and it's often kind of the first step in evaluating fertility or infertility. So ovarian reserve testing is essentially looking at how many eggs broadly a woman has in her ovaries. There's two ways to evaluate. One is with blood work, primarily a hormone called anti-Mullerian hormone. It's basically a hormone produced by the early eggs in the ovaries, and it comes back as a single number, and the higher it is, the better. And in general, AMHs higher than 1 are considered normal, but it's really an age-dependent number that we expect. So the younger we are, the higher our AMHs tend to be, because ovarian reserve naturally declines slowly over the lifetime. There's not a single age that's a cliff. It's just sort of a gradual process. So we can check AMH levels from the blood, really at any point in the menstrual cycle. We can also check it while somebody's on birth control pills, although AMH can be suppressed, 30 to 50% by birth control pills. So if a number comes back low, the first move is often to stop the birth control, give it at least a month to sort of wash out, and then check again.
That's so interesting. Why does the birth control do that?
Probably the sort of pool of early eggs is a dynamic group that's somewhat responsive to cues from the brain that are suppressed by birth control. So it's just a temporary suppression of the number of eggs sending out that AMH signal. It's all temporary. There's nothing about birth control that affects egg numbers or future fertility. But it can affect, while women are taking birth control, it can affect that AMH value.
Now, this is a little bit of a segue here, but I have patients that are convinced that when they've done birth control leading up to their IVF cycle, and this is used frequently for a number of reasons, that they've had a poor rendering in that cycle, that, comparatively to other cycles, and this can all be coincidence, obviously, but have you seen anything like this or heard anything from your patients like this, like that birth control, that maybe in the suppression can temporarily make, say, ovaries sleepy?
It's a good question. For years, everybody got birth control before starting an IVF cycle. It was considered part of the preparation for starting IVF. And, in more recent years, we realize it's not necessary, but we use it frequently for folks, when you need to schedule when someone starts their cycle, or, there's various reasons to consider using birth control leading into a cycle. It has been studied. It doesn't affect the final outcomes in terms of numbers of eggs retrieved or egg quality or final outcomes at all. It may lengthen the cycle by a day or two because the ovaries might be a little bit slower to respond. In general, a couple of weeks of birth control is really not going to do anything to an IVF cycle. If women have been on birth control for months and months before IVF, that might start to have an effect, that the ovaries are just, sleepy, slow to respond. So for women who've been on birth control for longer, I'll often take them off maybe for a month before starting. But this kind of short-term birth control use that's very common in IVF, it's been studied and it really shouldn't affect final outcomes.
That's super interesting and very, very helpful. But aside from birth control, are there other medications or other, life circumstances or things that could adversely affect ovarian reserve that are known?
Yeah, that's a good question. Not really. Not really, to be honest with you. It's really medications that are affecting our hormones, like birth control. There's another one called Lupron that some people might be on for endometriosis or other reasons that works like birth control, that it suppresses our hormones. That would have a similar effect. I will, in pregnancy, breastfeeding, which kind of works like birth control as well, like AMH isn't as reliable in those settings as well. So those are the main ones, basically, where our reproductive hormones are suppressed. AMH is, somewhat suppressed as well.
But it wouldn't be a lasting effect, so not like chemotherapy or radiation, which we're going to get into a little bit later in this podcast.
Right, yep. Exactly. Those, or removal of an ovary, like pelvic surgery, those are kind of permanent changes to ovarian reserve.
Got it. And in your experience with the anti-Müllerian hormone, have you seen it change, like go up? Have you seen it change positively? Because I've seen changes in this hormone with some of my patients, but it was like, is it just because it was a different lab? I don't know. Mm-hmm. So have you seen, it be a more positive change rather than a decline?
The sort of answer at the root of that is no, only in that we have a set number of eggs, and biologically and with reproductive sort of medications, there's no way to make that number higher. So AMH, more eggs won't pop up, which is really what we're hoping for with a higher AMH, right? Variations in AMH values, are more likely to reflect differences among labs, whether folks are on birth control or not. If someone's been very sick, in theory that could affect AMH and then they recover, so it looks higher. Generally, those variations are going to be relatively subtle. They're not going to be drastically different or drastically higher. I mean, that's kind of the holy grail of reproductive medicine. Like, how do we really increase the number of eggs in the ovaries? How do we make more eggs? How do we improve ovarian reserve? And there really isn't a meaningful way to do that, unfortunately. There certainly are some more experimental therapies put forth, but the data just doesn't support any of those yet. So yeah, it's mostly sort of subtle variation due to when the lab is checked and what assay is used, but not a meaningful so much increase or change.
That is very interesting what you say about, if somebody was ill and recover, that, maybe they had their AMH tested when they were ill and it was low, sort of, not their real number as if they were on birth control, for example, but then, they were in better health and their ovarian reserve, like their true ovarian reserve, showed back up in testing. That's kind of an interesting thing that I hadn't been aware of, and potentially useful in a way. I'm not sure if it would change outcomes, but just to know, for people's own understanding of if they were seeing variations. Now, go ahead.
It would just be like really significant medical illness, like hospitalization, generally like major things, not sort of, everyday sort of variations in health. Really, shouldn't have a major effect, but more like I've seen patients acutely ill, hospitalized, urgently get one level checked, and then it's, maybe different once they've fully recovered for that. Like we see that in cancer patients potentially. But yes, I mean, it is, overall health is a factor.
Interesting. Have you seen any changes with COVID?
It's a good question. I haven't, and I haven't seen data on AMH levels with COVID infection. That'd be interesting to know, but I have not. Yeah.
I mean, I think it's going to come about in the next while. We're 2 years in, and what is required is time for these things to be conducted. So it'll be interesting to see, the changes, if any. Hopefully not. Hopefully not. Okay, great. And now, some patients, they can have sort of like, they can do their IVF and they're getting maybe the same number of eggs every time, but then there are these changes where, they go from getting 2 one cycle and suddenly get 6, 7, or 8 another cycle. If we only have a set amount, what accounts for these changes?
So we have a set, we're born with a certain number of eggs, and each month 1,000+ eggs are earmarked for consumption. 1 is ovulated and the rest break down. So that's sort of a steady march over time. In an IVF cycle, we're using medications to recover more of those eggs that were earmarked for use kind of anyway, and get those to grow and retrieve them. But, the number that out of that pool that's going to be consumed, the number that respond to the medications, it can vary. Unfortunately, a lot of IVF is luck and trial and error, which is a little bit disconcerting, as a science. I mean, definitely as a science, but there is this, luck and chance and try again aspect. And, the variation among cycles might be, changes to medication protocols, kind of overall health, one cycle to the next. I have had patients who start doing acupuncture and yield improves. It just varies patient to patient because everyone's physiology is different and we're seeing what works. In general, response tends to be fairly consistent, but there are other patients for whom one protocol is really good and another is not. So it's a combination of the medications, the dosages, other health circumstances and luck.
Yeah. Interesting. Yeah, because I think that's a question that comes up is like, even if the ovarian reserve is low, is there the possibility that you could maybe get a better cycle according to, the variables that you're pointing out. So that's really interesting. What other markers besides anti-Müllerian hormone are used to assess ovarian reserve and like candidacy for IVF?
Yeah. AMH is the main one. We do also check cycle day 3 labs, which means FSH, which stands for follicle stimulating hormone, and estradiol. We check those 2 things together on the 3rd day of the menstrual cycle, which is because those lab values can vary a lot. You have to check them at a very specific time, unlike AMH, to get a reliable answer. And whereas for AMH, the higher the better, for FSH, within reason, it's the lower the better, because FSH is a signal sent by the brain to the ovary to get eggs to grow. And the signal of eggs growing is estrogen, estradiol production, which then feeds back to the brain. So FSH and estradiol are talking in a cycle to each other. So, you want FSH, definitely below 14, ideally below 10, and an estradiol to be below 80. As those values get higher, it's a sign that the number of eggs in the ovaries is lower, and the brain is having to send a stronger FSH signal, a higher FSH amount to the ovaries to get an adequate response. So a higher FSH is a signal of lower ovarian reserve. In general, AMH tends to go lower before FSH goes higher. A higher FSH is a poor IVF. It's not that someone can't do IVF. It just means that the egg yield is expected to be lower, and there may be a higher chance that the ovaries, in a cycle may not be able to respond. The important thing to know, though, is none of these tests, AMH, FSH, estradiol, none of these tests reflect egg quality. So quality is frankly more important than quantity, but it's harder to quantify because there's no test for it. Egg quality is sort of the proportion of eggs that are genetically normal and healthy and can make a healthy baby. And it goes back to the idea that we're born with all the eggs we're going to have. So over our lifetimes, just by chance, eggs accumulate little errors, little changes that mean when it comes time to try to get pregnant and we're ovulating one egg in a month, the odds that that egg is healthy and genetically normal changes. It starts through the 30s, particularly the mid 30s into the later 30s, and then more so into the 40s. So it's an age-related change. And so AMH and FSH have nothing to do with that. And there's a very good study showing that looking at groups of women, one group with abnormal ovarian reserve markers, whether that's AMH or FSH, and the other group with normal reserve markers, and then they start trying to get pregnant, they have the same time to pregnancy, because it's really age that's the determining factor. So, ovarian reserve is the main thing that we can check, but it's really only part of the picture. It predicts how many eggs you might get in IVF, but it's poorly correlated to the final outcome, normal embryos, pregnancy. That's really determined by age.
Yes, because I've had patients that have been like 43, 44, 45 who've had still an AMH of say 3, and they get maybe 30 eggs, but none of them turn out to be viable. And then, but similarly, I've actually had 20-something-year-olds that have gotten 30 to 50 eggs and none of them have been viable. And that's obviously much less common. But it's been an interesting anomaly that you would think at that age with that amount of eggs that you would get something out of it.
Yeah. In one of the major studies, there was a little sort of uptick in embryo quality and thereby egg quality issues sort of in the early 20s. And it's unclear why that is. It's probably a little bit of a confounded patient population because they're doing IVF in their early 20s. Like there must be something going on, but there definitely are surprises in egg quality. So there's definitely aspects of egg quality that we don't completely understand. And there absolutely can be surprises. Yeah.
Have you seen any patterns with your patient population aside from age in terms of like things that might influence egg quality negatively?
Yeah, it's a great question. We know that smoking is not good for egg quality. There's some kind of observation that sometimes women who have very, very high egg counts may, certainly not always, but may sometimes have egg quality issues. And we're not entirely sure why that is. Probably genetic in part. And, women with very high egg counts sometimes have PCOS, sort of a syndrome of higher testosterone and irregular cycles. And, it's not a global truth about this clinical scenario, but anecdotally, we do sometimes see that women with very high AMH or egg yield may have issues with quality. But in terms of modifiable things, smoking is a main one. There's, some thought about obesity and egg and embryo quality. But really at the end of the day, age is the major factor.
Of course. With the obesity, could it be potentially, this is speculating obviously, but like consistently elevated blood glucose or insulin levels maybe?
Yeah, I don't think we totally know, to be honest. But, that's some of the concern, other metabolic issues. Some observations about inflammation and excess adipose, like fat tissue. I think we basically don't totally know. It's probably a combination of things.
Hopefully there will be more research on the
Yeah.
lifestyle factors, so we'll have even more understanding. In the meantime, my approach is just to get all the patients as healthy as possible.
Yep.
Do all the things that we have control over that,
Mm-hmm.
make you feel more empowered physically and mentally, but hopefully
Mm-hmm.
will also improve outcomes in unknown ways.
Yeah,
Yeah.
absolutely.
So you are the director of oncofertility at Columbia University Fertility Center, and we are going to get into cancer diagnoses and what that means for patients dealing with this to be able to conceive. But aside from cancer, what other circumstances would you recommend urgent freezing of eggs and embryos?
It's a great question. Anything that's going to long-term affect, like permanently affect the number of eggs in the ovaries. So, there are non-oncologic reasons that women might be having major pelvic surgery. There are benign ovarian cysts, endometriosis, again, sort of a condition of benign, but basically tissue in the abdomen causing scarring and pain. Any reason for having major pelvic surgery, could affect ovarian reserve and could be a reason to consider fertility preservation before that. That's usually, the main time to consider urgent fertility preservation. Surgical or chemotherapy or radiation exposures that are going to long-term affect the number of eggs in the ovaries. I've had the occasional patient who's going out of the country on assignment for a couple of years and they're in their early 30s now. And this is the moment before they go abroad where laws might be different and access might be different. And now's their chance. I mean, that's another thing to consider. If there's something coming up in life that's going to delay conceiving or freezing eggs for years, and, at least to consider, do I have the opportunity now to preserve for the future? That sort of thing comes up sometimes.
Do you think that, say someone does their baseline and their fertility tests and it's found that the AMH is low for their age and they're in their, say, like early mid 30s. Is this a circumstance where you'd say, maybe you should freeze if you're not planning on having kids anytime soon, or like when would you give the advice to say, you should start planning for the future?
Such a good question. It's the question because, there's direct to patient advertising for AMH testing now, and patients are getting these AMH. Yeah, there are some mail order blood tests and patients can get their AMH tested directly, which, I have no problem with, but it has to be presented in the right context that a low AMH does not mean infertility.
Right.
A high AMH does not mean fertility.
Right.
It has to be interpreted in context of overall, health and plans and age. But that is a tough question. It depends on how low it is. It depends on whether there are signs of impending perimenopause, which is usually when FSH is starting to go very high. That only affects about 1% of women under age 40, but it sort of depends how low it is. In general, generalizing, we don't always know that this is true for an individual, but AMH is thought to change pretty slowly, maybe about 5% per year. So I have plenty of patients where we find a kind of borderline low AMH at one point, and 2 to 3 years later, it's the same. AMH does seem to change a little more precipitously at the end of the 30s and definitely into the 40s. So I never want to say like, don't worry about it, it'll be fine. But particularly in the early 30s, it's unlikely that it's going to change that quickly. And so on the one hand, that's very reassuring. And some patients take that information and sort of say, maybe I'll check my AMH in a year and just make sure it's not changing too much. But, I think I'll just kind of wait on this. And then there are others where, the general expectations of AMH are reassuring, but we don't know that it's true for them. And they would feel more reassured by freezing some eggs now. with the counseling that they may never need them. If they start trying in a few years, AMH very well might be very similar. And at that point, it's age that predicts getting pregnant, not AMH, and they may never need these eggs. So, I think awareness of ovarian reserve and reproductive aging is awesome. I mean, information is power, but it sometimes leads to panic that is not warranted or interventions that are not needed. And, AMH is a limited part of the fertility picture, basically.
Mm-hmm. I think it's a really good point that you say, like, this has to be in context of the entire picture. Their life plans, their age, right? Because we just talked about how even if you have a high AMH in your 40s, it doesn't necessarily mean that you're going to render something of quality, right? So that's really good for patients to know, to not take that number and kind of make all decisions based on that, and to have a conversation with your doctor about what makes the most sense for your life now and for the next few years. So that's really helpful information. Thank you. You're very good at explaining things. So
thanks.
Yeah, diving into cancer patients. So what are the unique challenges? Obviously, you mentioned that, chemo and radiation will diminish their ovarian reserve. I imagine it's also kills sperm. But, is it different for the types of cancer when they should, when they should consider freezing? Like, they have to do it right away, but when they have the diagnosis, is the cancer itself going to, kill their fertility? So a bit more information overall on this population and what they have to consider.
Yeah, it's a great question. And, the effects that cancer will have on fertility does depend on the type of cancer and the planned treatment, for sure. So, gynecologic cancers, which are fairly common and can affect young reproductive age women. I see plenty of patients with uterine cancer, which may result in a hysterectomy. As long as patients have their ovaries in place, they could produce eggs, make embryos, that kind of thing. But then there are ovarian tumors or ovarian cancers where the ovaries have to be removed. So gynecologic cancer, presents a range of potential fertility effects that really depend on like where the cancer is and whether the treatment will be surgery, chemo, or radiation. The other cancers, so the most common cancer that we see is breast cancer. And there's a fair amount of hematologic malignancies as well, like leukemia, lymphoma, things like that. The fertility effects of those cancers really depends on the chemotherapy that they're going to get. There are some chemotherapies that are particularly harmful to ovarian reserve, and those are called alkylating agents. They basically induce depletion of egg counts. And so if we know that a patient is going to be getting an alkylating agent, we're, particularly inclined to preserve fertility before chemo. Same thing with platinum agents, which are used for a variety of types of cancers. There are other chemo regimens that are really not so bad. Some sort of medications in the kind of antibiotic family, and there's some immunologic therapies that may not be as bad, though they're not as well studied. So there are some chemos that are not as bad. The bottom line is, though, that there's a lot of unknowns in how these medications will affect fertility. So most patients that are coming to me will ultimately do fertility preservation because, it's a priority if they've come to my office, and there's enough unknowns that if we have the time and ability to freeze some eggs or embryos, we'll do that. The other thing with breast cancer that's tricky is that if a tumor has estrogen receptors, patients will be on medication for 5 to 10 years after their cancer treatment to block estrogen and reduce the risk of recurrence.
Is that the tamoxifen?
Yeah, tamoxifen usually. Very effective, but you can't get pregnant while you're taking tamoxifen. It's not so much that the tamoxifen doesn't affect fertility, you just can't get pregnant while you're taking it. Right. So there are some cases where patients can stop tamoxifen after 2 or 3 years, have a baby and go back on it. Some patients want or need to do the whole 5 to 10 years. So now it's not so much the medication, but it's the time that they won't be able to conceive. So now we're thinking about reproductive aging.
Mhm.
And even in patients who are not getting chemo, but will be getting tamoxifen, we do fertility preservation for a lot of them because it's going to be a couple of years before they can even think about this. So it's a combination of things. Where is the cancer? What's the treatment? When could they try to have a baby if they wanted to? Thinking about reproductive aging and like putting all of those things together. Also, some patients know that they will need or want gestational carriers. So their pregnancy carried by another individual. And in that setting, they'll often do fertility preservation sooner because they know they're going to need embryos for a gestational carrier anyway. So there's so many variations on this.
That's really interesting. On the topic of breast cancer, reproductive cancers that may have estrogen receptors. Now, when we do an IVF cycle, we generally have a rise in our estrogen levels. Now, I have patients ask me, and I don't know the answer to this question, frankly, it's not my area, but can all these medications contribute to breast cancer or other cancers that are estrogen receptive? And if there's already cancer there, could it cause the proliferation of the cancer?
Yeah, it's a great question and a common one. The answer is that research pretty convincingly and reassuringly shows that fertility treatment and these medications that we use does not increase the risk of breast or ovarian cancer. There's one study that somewhat unconvincingly suggests maybe an increased risk of what's called a borderline ovarian tumor, which is not cancer. That's sort of a separate thing, but overall the answer is no, that these treatments really do not appear to increase the risk of those cancers. What research has also shown that's very interesting and confounds this question is women with infertility have a higher risk of breast cancer and GYN cancer, whether or not they do fertility treatment. So that's the point. Yeah, that's the point that studies missed for many years, that it's not the treatment, it's the underlying medical condition that we're treating.
So they already had a pre-existing predisposition to this. And the treatment itself did not increase the odds. Right. Their predisposition was already there. That is very interesting. Right. Is there any kind of indication of what creates that risk? What profile of person or their, genetic predispositions?
It's such a good question. We don't know because risk is so sort of multifactorial as well. We don't totally know. I mean, we know that breastfeeding reduces risk of breast cancer. So folks who've had a pregnancy and breastfed are potentially at lower risk, but, we don't really know what profile has, or what about infertility increases the risk of these things. But in relation to your question about patients who already have estrogen receptor sort of positive tumors, research has also shown pretty convincingly that fertility preservation doesn't change the stage or overall survival from these tumors. And part of that is that we can block estrogen levels during a cycle with a medication called letrozole to not, to basically prevent those high estrogen levels during the cycle. And then, once women are, well in remission from their breast cancer, pregnancy actually, hasn't been shown to increase the risk of recurrence. So overall, data is reassuring.
That is reassuring. That's comforting. I've been wondering about that for a little while. On the topic of letrozole, I know we're running out of time. The letrozole kind of suppressing the estrogen, would that help with some of the unpleasant symptoms in an IVF cycle? All that bloating and mood changes as the estrogen level rises?
Yeah, it's a good question. I haven't really seen that to be true, honestly. Letrozole hasn't convincingly been put forth as a way of preventing ovarian hyperstimulation, which is that syndrome of bloating and enlarged ovaries and all of that. So I think it's not as helpful as we might hope it would be, because it's really not estrogen, I think, that's doing all of that. I mean, the ovaries are bigger than usual, whether or not you're taking letrozole, and there are other kind of hormones produced by the follicles, whether or not folks are taking letrozole, that really drive all that bloating.
Fair enough. Fair enough.
Yeah.
Well,
Yeah.
thank you so much for being with us today, Dr. Brady. This was really a great conversation. Where can patients find you?
Oh yeah. Well, thank you so much for having me and everything you do for our patients. I, love working with you and your center. I can be found at the Columbia University Fertility Center. You can give us a call, make an appointment. I'm also on Instagram and Twitter, and try to post scientific findings and my own experience as an IVF patient in the past. So you can find me in all of those places.
Oh, that's so great. We can get real-time info from Dr. Brady on social media. So
Yeah.
listeners, thanks for tuning in. I will be posting all of Dr. Brady's info, her social handles, and the contact information for Columbia Fertility Center. I highly recommend her. I get great feedback, and we'll hope to have her back next time for another round.
Thank you so much for having me. It's great to be here.